Good evening, everybody, and welcome to this, the fifth in a series of live webinars hosted by the team here at the UKGIM. Thank you very much for joining us this evening. As you know, we've been putting on a series of webinars through 2020, really since the COVID pandemic started, to try and ensure that there's still access to free or inexpensive, high quality CPD. This evening's webinar will be 1 hour, and it'll be an update on the management of stroke. And we're very lucky to have our guest speaker with us this evening, Dr. Nick Evans. Nick is a consultant physician and stroke physician at the University Hospitals Dorset NHS Trust, where he works both on the acute medical on-call as a geriatrician and also on the new hyperacute stroke unit. Nick has a very active role in medical education and is also a very keen kite surfer in his spare time. I'm going to hand over directly now to Nick. I know we've got a full programme this evening. As you know, Nick will be talking for around 40 to 45 minutes. There's the opportunity to ask questions via the question function. And as the chair, I will try and bring together any themes and ask any questions directly to Nick at the end of the session. So that's all from me, and thanks very much for joining us this evening, Nick. Over to you.
Great, so thanks everyone for joining this evening. So as Adam said, my name's Nick Evans. I'm a stroke consultant and geriatrician here at University Hospitals Dorset, currently in Poole Hospital in my office. My declarations before we start. I do receive speaker fees from Pfizer and Bristol Myers Squibb, the makers of Apixaban, and I've also had conference sponsorship from Bayer, who make Rivaroxaban. We're not going to be talking too much about the DOACs today. So what I thought we'd talk about today is a brief overview of stroke to start with, then a little bit about hemorrhage and sort of a couple of changes there in the last few years, before moving on to thrombolysis. I'm not going to go into a lot of depth about thrombolysis because that is something that's been around for quite a while. But I will go into quite a lot of depth about thrombectomy, which is sort of the new kid on the block in stroke and very exciting. And then just a little discussion about what I think the future holds for stroke. And then we'll round up at the end, like Adam said, with some questions. So stroke's important. It's still the fourth leading cause of death in the UK after dementia, ischemic heart disease and COPD. So still more deaths from stroke than cancer of the lung. So an important problem, currently about 35,000 deaths per year. The incidence of stroke is high. It's 152,000 people suffer a stroke each year. And really crucially, stroke is really, has a really high mortality rate and a really high disability rate for those who survive. So 1 in 8 strokes are fatal within 30 days, which is a huge figure. And 1 in 4 strokes are fatal within the first year, often due to complications of stroke and the deficits that stroke survivors are left with. Again, really important is that half of all stroke survivors are left with some form of disability, and 1 in 3, so a third, essentially are dependent on others for care. So real massive impact on people's function should they survive the stroke. And that not only has implications for stroke survivors themselves, but also on society, because we're seeing more and more young people affected by stroke. And clearly, if they're dependent on care for many years following their stroke, that's a huge financial burden, on society. And also, it's a huge financial burden on their families and themselves because they don't have the capacity often to work, and that's a real big issue. So the more strokes that we can prevent, clearly, the better. And that's really what acute stroke's all about, and what I'm going to focus my talk on this evening. So, as with lots of other medical conditions, we are getting better at improving mortality from stroke. So this figure quite nicely demonstrates that. And you can see that in the sort of the early 2000s, there were about 70,000 stroke deaths per year. And that's now just about halved to about 35,000, as we talked about earlier on. That's the blue line there that's indicated by the red arrows. Clearly, it's multifactorial as to why that's happened, and that's a broad spectrum across primary care, secondary care, and public awareness of stroke as well. The things that probably as secondary and primary care physicians you'll have seen happening or be aware of in the world of stroke is that really in the last 10, 20 years, we've had dedicated stroke units, dedicated stroke physicians, and dedicated stroke therapy teams, which have made a huge difference on stroke recovery. And it's stunning to think that, you know, years ago that patients who had a stroke would just be admitted to a general medical ward without all the dedicated stroke input they get these days. So that's definitely somewhere that we've come a long way. Stroke's really heavily audited, and has been since the late 90s, and I think that really drives improvement and drives change. So all stroke units in the country are subject to the Stroke National Audit Project, or SNAP, which you may have heard of. And that's basically a measure of how well stroke units are meeting targets. And those targets are things like direct admission to the stroke unit, early swallowing assessment to prevent aspiration pneumonia, early review by a stroke physician and stroke therapists. And these are all proven interventions which are shown to improve outcome from stroke. And being part of the national audit and basically able to compare ourselves to other units is really important, and something which I think is really valuable. There's been a recent drive to centralise hyperacute stroke units and to have what we call HAZUs, which essentially are where patients come in the first 72 hours of their care or longer if needed. And we'll touch on the reasons for that a little bit. Clearly, having a 7-day service is really important, and there aren't loads of stroke physicians out there, so there's quite a few unfilled posts at the moment. And it's felt that actually having hyperacute stroke units where, you know, 24/7 thrombolysis covered by a stroke physician and 7-day ward rounds are valuable. Certainly this has been trialled since the sort of early 2010s in London and Greater Manchester, and has been shown to benefit patients. So in London there was a reduced mortality following centralisation of these units, and they've calculated that about 100 patients a year won't die from stroke because of centralising. Length of stay has been reduced across Manchester and London. And those targets that we talked about with the audit are met more frequently when stroke services are centralised. Clearly, this is not without difficulty. So, you know, centralising stroke units does mean that some people will have to travel further. That goes for both patients and staff. And certainly, Adam mentioned that Poole and Bournemouth hospitals have recently merged as trusts. The stroke units are sort of leading the way in terms of merging services as well. And our HAZU opened just a couple of months ago over in Bournemouth. So all these strokes from East Dorset now go direct to HAZU, where there is a 7-day stroke physician-led service, which is clearly progress. That does mean that rotas are a bit more tricky, and that staff are having to move around, which initially is quite difficult, but clearly there's a benefit for patients, and therefore that's the right thing to do. And that's something I think will become more widespread. I think the message really from all of this is that, you know, stroke care is best done on a stroke unit by stroke specialists, doctors, nurses and therapists. So if you're coming across patients who've had a stroke on your medical take or in ED or anywhere really, if they're being referred into, you know, the medical take, I think that the key point really is to early discuss with a stroke physician or the stroke team and get them admitted directly to the unit where they'll receive the best care. So I thought we'd move on now and we talk a little bit about hemorrhage. This is a hemorrhage shown on a CT scan, so a hyperdensity in the left basal ganglia. This one has extended into the ventricle. Hemorrhage is sort of one of a stroke physician's worst nightmares, really. A, because it has a very poor prognosis compared to other types of stroke, and B, because it's a sort of a stroke that we can't really do very much about as stroke physicians. So we obviously like to do things. And ICH is unfortunately one of the things that there aren't much that we can do as a stroke physician. The things that we can do and that you'll be aware of, this is sort of things that have been around for a long time, are reverse coagulopathy. So we know that things like warfarin and more recently the direct oral anticoagulants are a risk factor for having an ICH. And clearly, once you've had your ICH, you don't want to keep bleeding, so reversing those is a priority. Warfarin, as I'm sure you're aware, is IV vitamin K and prothrombin complex concentrate. The DOACs now, there's a number of DOACs. There's dabigatran, which has its own reversal agent in the form of Praxbind. So that's important that we give that. The other factor 10A, so apixaban, rivaroxaban and edoxaban, don't currently have an easily available reversal agent, although that is in development. And the current recommendations are to give prothrombin complex concentrate in that situation. This is something we've been doing for a long time. Unfortunately, patients don't tend to have their stroke in hospital when it's a hemorrhage. And by the time they arrive, there's already a significant volume of hematoma there. So although we do like to reverse coagulopathy, we need to be mindful that actually a lot of damage from that stroke has already been done. So although it's something we can do and should be doing, we'd like to do more. I've just discussed about getting people to the stroke ward ASAP. That's really important with hemorrhages as well as infarcts. And primarily that is because of things like a rapid swallow screen to assess those who are at risk of aspiration, GCS monitoring for complications such as hydrocephalus, hematoma expansion, seizures, all the sort of things that come along with complications of stroke, which the stroke nurses and the stroke staff will be very alert to and constantly monitoring for. The sort of more recent thing that's changed slightly maybe in hemorrhagic stroke is blood pressure control, and this is always a sort of debated topic amongst physicians, primarily because these bleeds are arterial, so it would make sense that reducing systolic blood pressure might reduce hematoma expansion because you've got less pressure pushing the blood out. On the flip side of that, the sort of hemodynamics of the brain are altered when someone has an intracerebral hemorrhage, and the regulation is dysregulated. And there was a school of thought that actually reducing the blood pressure might cause infarction of tissue around the hematoma because of hypoperfusion. And this was debated for a long time. A recent trial, I say recent, 2013, not that recent, called Interact-2, published its results. And I think the key findings really from that were that there was no adverse effects of reducing blood pressure below 150 if people were hypertensive at the time of their bleeds. So people within 6 hours of their intracerebral hemorrhage being diagnosed, if their blood pressure could be reduced below 150, it didn't show that they had a worse outcome than those who weren't reduced. So actually, the theory that actually reducing cerebral blood flow and causing this sort of perihematoma infarct didn't really materialize, which is good news because it means that there is something that we can do for these people. There was a modest shift in disability score, so people at follow-up were less disabled than the control group. The p-value was 0.04, so it just about reached significance. I'm going to talk a little bit now just about MRS scores or modified Rankin scores, because it's something I'm going to talk about when I talk about some other trials in stroke. So for those of you who haven't seen the modified Rankin score, this is essentially a disability score that goes from 0 to 6, where 0 is no symptoms whatsoever and 6 is death. And obviously there's a sort of sliding scale going down there. And really, in terms of recovery from stroke, we want to get people into a 0 to 2, ideally 0 to 1 modified Rankin score, where they're either asymptomatic or their symptoms don't really inhibit them from their activities of daily living. I say 0 to 2 because some of the trials do include 2 as a good outcome, although one might argue that that they're not able to get back to their previous quality of life, so it's maybe not as good as 0 to 1. So that's something to keep in mind when we talk about sort of good outcomes. So a good outcome really is 0 to 1 on the MRS score. And as I said, the Interact-2 trial did show that people did move up a disability score, and that can be quite significant. So, although saying 1 on that score isn't too much, that could be the difference between needing a nursing home or a residential home or being able to go home with some care. So clearly from a patient level, the difference of just 1 modified Rankin score can be very significant to their lifestyle and to what care they might require. So key message really from the Interact trial, and this is recommended in all the guidelines now, is that if a patient's blood pressure is more than 150 systolic within 6 hours of the diagnosis of the ICH, that it is worthwhile reducing the blood pressure to below 140 and trying to sustain this for 7 days. They don't recommend how to do this, and really that's down to local policy. Our policy in Poole, or what I prefer, is using labetalol, just because I think it's got a longer half-life and therefore is easier to give in the longer term. I know other people prefer to give GTM because it's a bit easier to titrate and get in quickly. So really down to preference of the trust that you work at there. But clearly trying to get that blood pressure down and reduce it doesn't cause harm and can improve people's disability scores longer term. That's pretty much all I have to say on hemorrhage. As I said, hemorrhage is one of those things that we get frustrated at because there's not a lot we can do. But reducing blood pressure and getting them to an acute stroke unit are really the things that make a difference there. So moving on now, the scan that you'll see on your screen is an infarct. So this is someone who's infarcted their right MCA territory. This is a CT scan that shows hypodensity. So when the brain is hypodense, it's essentially infarcted and dead and insalvageable. Clearly, this isn't what I want to see when I see someone at the front door. So if someone has this imaging, it sort of means that they've missed the boat, and that there's not going to be a lot I'm going to be able to do acutely for them to try and prevent a stroke, but rather we'd have to deal with the consequences of that. The CT I want to see is something like this, so a normal CT. So someone who has symptoms but a normal CT is someone who I can potentially do something for. So this is the CT that I want to see. I'm sure that you'll all have heard of time is brain from stroke physicians. We love that phrase. And you know, stroke is an emergency. That's something that, again, we like to sort of try and get over to people. There's been studies that show that about 1.9 million neurons a minute are lost during a stroke, which is a lot. Obviously, we've got billions of neurons, but each of those is doing something. And even people that we catch quite early who are having strokes and who have quite small infarcts and MRI often are left with very subtle problems. So, you know, you see them in clinic a few months later, and although they appear to have made a full recovery initially, they are left with subtle problems that's probably as a result of, you know, some of these neurons dying and causing functional problems. The quicker we get treatment, clearly, the better, and the more we reduce dependency of patients and their symptoms afterwards. And I think at this juncture, it's worthwhile just reminding ourselves about stroke and about, you know, physiologically what we're talking about. So I quite like this demographic, which is of a sort of normal circulation. And you can see here that the MCA is represented at the bottom, so the big middle cerebral artery coming into the brain. You've got the anterior cerebral artery coming down from the top. And really what this is demonstrating is that a lot of brain is sort of dual supplied by a number of arteries. So there's a lot of anastomotic supply. And therefore, if you block one artery, you'll often have a little bit of feed from other arteries that can sustain the brain for a little while. Clearly, when you have a clot, you'll block a part of the brain, and part of it will die, so you'll have an infarct. And the sort of the dark grey shading there represents part of the brain that is insalvageable. So that bit of brain is dead, and even if you remove that clot and got brilliant blood flow, that bit of brain will not come back. What we're interested in is the penumbra, which is the area of brain that is ischemic and not functioning, so it's still causing symptoms. But actually, if you restore blood flow to that area of the brain, you've got a chance of recovery. So that bit of brain is salvageable and therefore worthwhile trying to save. And you'll see at the top there that there's collateral circulation, and that's going to be quite important for some of the discussions that we have later on. So moving on now to thrombolysis. As I said, there's lots and lots of trial data and lots of studies on thrombolysis, some of them as early as 1960 in stroke, which is interesting because that was before CT scans. So in those trials, patients who presumably will have had hemorrhages probably received some thrombolysis. Clearly not a trial that we could do these days. The very clear outcome from these trials is that thrombolysis does cause early death. So in the first sort of 10 days, thrombolysis causes early death. And the main reason for that is because infarcted brain or ischemic brain is more likely to bleed, and therefore putting thrombolysis in, which you know thins the blood and does make blood vessels leaky, can cause early intracerebral hemorrhage. So it's perhaps not surprising that early ICH and early death is seen in all the trials. What the trials do show us is that when you look sort of after the hyperacute situation, the all-cause death does start to reduce after day 10. And actually, when you look at 6 months, a year down the line, the all-cause death is neutral at follow-up. So longer term, we're not causing an excess of deaths by giving thrombolysis. This is a figure that's taken from the NINS trial, which was done quite a while ago. And essentially, it's looking at the modified Rankin scale of patients who are given thrombolysis. And you can see here that there is some patients who have worse outcome, and they're probably the ones who have the big ICHs that are symptomatic. They're the sort of red figures down at the bottom. But there's a fairly large proportion who have an improvement in their MRS, modified Rankin scale, and they're the sort of the green figures. And it's around a third. So a third of people will get a decrease of MRS score of about a point. So that's putting you up on that scale to slightly better function than placebo. And this is what I tell my patients or the relatives if I can't tell them themselves. So from that last figure, I tell them that there's about a 1 in 3 chance of some improvement. So it might not be back to normal, but it's a chance of going up that scale. A very good outcome, which would be classed as a modified Rankin scale of 0 to 2. The chances sort of decrease the longer that we leave things. So these figures, we sort of call it the rule of 5. And it's the easy to remember way. It's not exact. But if you catch a stroke and you manage to thrombolyze someone within an hour and a half of symptom onset, you've got about a 1 in 5 chance of having a good outcome, which is either asymptomatic, being symptomatic but it not interfering with your ADLs, or being minorly symptomatic and not being able to go back to all your ADLs, but being able to look after yourself, so be independent, which is clearly a very good outcome. So 1 in 5 people, if you catch them within an hour and a half, that then goes to a 1 in 10 between an hour and a half and 3 hours. And then beyond 3 hours to 4.5 hours, that goes to about a 1 in 15. That's a slightly tricky time window, particularly in over 80s, and you have to sort of pick your cases quite carefully there, because actually the risk of having a severe bleed in that time frame is about a 1 in 15. So actually the benefits are fairly equal with the risks. And in our sort of elderly population, the risk of bleeding is often higher, which is why we proceed with caution in over 80s beyond 3 hours. Beyond 4.5 hours, the chance of a very good outcome is less than 1 in 15, and therefore the chance of bleeding symptomatically, having a major bleed, is more. And so the time cutoff is 4.5 hours for thrombolysis because of that. And it's important to warn patients there is a chance of death, and that's particularly significant in people who've got sort of lower severity strokes, and the risk of death is there. It's a 1 in 30 chance. I would balance that with saying that actually, as we talked about earlier on, the chance of you dying from your stroke is about a 1 in 4 in 6 months. So that's got to be balanced with saying, particularly with those people who are having very severe strokes, who've got high disability scores because of the stroke, that actually the chance of dying of that is very, very significant. And yes, there is a chance of dying from the thrombolysis, but it's probably warranted. So those are sort of the figures that I would usually go through. I'm just going to have a quick drink. Before moving on to the really exciting bit of stroke, which I'm sure you've all heard about, which is thrombectomy or mechanical thrombectomy. So I've got some nice pictures here, and this is from a case that I saw during my stroke fellowship, so a real case. This is a CT angiogram, which really nicely demonstrates sort of how thrombectomy works. So a CT angiogram, the X-ray of the bone has been subtracted, so all you're seeing here is contrast in the vessels. I put the ears and the eyes on just to demonstrate sort of where we are in the head. Over on the left-hand side there, you can see contrast that's filling the common carotid artery. It's coming in just below the eye. That's then coming into the inside of the skull, and then dividing into the middle cerebral artery and the anterior cerebral artery. So the middle cerebral artery traverses out laterally towards the left ear, and the anterior cerebral artery sort of comes medially towards the falx and then travels up towards the falx. So I'm sure that you can see that there. And that's a normal cerebral angiogram there. So you've got nice chunky middle cerebral artery there on the left-hand side towards the ear, big chunky anterior cerebral, and lots of vessels coming off that distally, supplying the areas of the brain. And clearly, because this is the left MCA, this is supplying all your dominant cortex. So you've got your Broca's area, your motor cortex, your sensory cortex for the right side. Very important area of the brain. So this patient that we saw had a left MCA infarct clinically. So he came in dysphasic, completely paralyzed down the right-hand side with a hemianopia inattention to the right-hand side. So clearly a large left MCA infarct with lots of the left MCA territory of brain unhappy and ischemic. As you can see from the angiogram that we have here, we've lost the left MCA. So that nice artery that was traversing out to the left has gone with all its tributaries. And again, if you look at the image there, you can see what we've lost. So we've lost a huge amount of vessels there and a huge amount of blood flow to brain, which is now ischemic. This chap presented quite early. I think it was about 2 hours. So from the sort of the time window, we were sort of well within thrombolysis, and he was thrombolyzed, but didn't improve after that. So then went on for a thrombectomy. What we can see here is that an interventional radiologist has put a catheter into the femoral artery, I think on the left-hand side here, and fed a catheter up past the ascending aorta into the left common carotid, and has then gone all the way up to the internal carotid, and has put the catheter tip, which you can see is a little circular thing there, at the beginning of the clot. So where that clot was in the left MCA or left middle cerebral artery. The radiologist has then put some suction on the catheter, and you can see already that actually a little bit of that artery has opened up. So a little bit of clot has been sucked out. A few of the small striate arteries have opened up, so you can see that little sort of flush of arteries that's just come up in the middle of your screen there. But there's still a huge amount of vessels that are still lost over on that left-hand side. So going on to the next slide, what's happened now is that the radiologist has put a wire through the clot and has then injected a little bit of contrast down the other side, and we can see that the wire is past the clot because contrast is now flowing in those distal vessels. A stent has then been inserted over that wire, and you can just about see where the vessels are starting to open up at the proximal end. There's some little blobs. I think maybe you can see my marker there. Little blobs, which are the end of the stent, which has been inserted. So a stent has been passed across the clot and is ready to be deployed. The next sort of infographic shows what happens when that stent's deployed. So a sheath is taken off that, and the stent is spring-loaded and actually is required to expand into the clot. So if you look at the sort of end-on section there, you can see the struts of the stent starting to expand out into the clot. And unlike coronary stenting, where the stent sort of pushes the clot into the wall of the artery, what actually happens here is that the stent embeds into the clot. And after 4 or 5 minutes of the stent doing that, where essentially it's a waiting game to allow that to happen, the whole apparatus is removed, including the stent. And what you hopefully will get is a nice clot on the stent, as you can see here. So stent and tubing removed with clot attached to it. And again, this is the actual clot that came out of this gentleman's head. So this is the result. So you can see now that all the equipment's been removed, and we now have a pretty good middle cerebral artery with nice distal vessels. It's still looking a little bit ropey there, so where the clot was, it's still not a perfect vessel. There is still a little bit of stenosis there, but actually blood flow is really good now. Distal vessels are now pacified. And actually this gentleman did really, really well. So after a few days on the hyperacute stroke unit, he was discharged home with some help and with some persistent symptoms of some dysphagia and right-sided weakness. But actually, one would have thought that if that clot remained where it was and the whole of the left MCA territory was wiped out, he would have had massively significant symptoms and probably would have required a significant amount of care at home, if not 24-hour care. So a really excellent result from that procedure. That's just an image there just to show you the sort of before and after, really, and you can see a really nice result there. So trials in thrombectomy, the previous trials didn't show much help with thrombectomy, and I think that was probably due to patient selection and the old tech that they were using. Certainly the newer trials that were done sort of in the mid-2010, so around 2015, clearly showed that the independence was increased after a thrombectomy, and actually the numbers needed to treat were really, really good. So number needed to treat of 5 to get an MRS score of 0 to 1. So that's that excellent result where the patient's independent. Differing to thrombolysis is the amount of deaths or ICH early. So actually there's no difference in deaths or early ICH, which is something which reassures patients. And actually the number needed to treat to get some improvement, so climbing up the MRS scale of 1 is actually even less than 5, so it's somewhere in the region of 3. So it's clearly a therapy which it works really, really well, and the numbers needed to treat are really excellent. That's really demonstrated on this summary of the results from these trials. And what this looks at is the modified Rankin scores of people who don't have the thrombectomy, so the sort of placebo controls at the bottom. And you can see that of those people, it's sort of a roughly third divide of those who have an excellent outcome over on the left-hand side, a not so good outcome in the middle, and then a terrible outcome over on the right-hand side. Compare that with those who've had thrombectomy on the top line in blue, and we can see there's a huge shift there of people who have been quite disabled from their stroke or who have died from their stroke, who actually who get better. So you'll remember, sorry, when I said there was no difference in death, the people who are moving from that MRS score of 5 to 6 are those who will be severely disabled, who actually then become less disabled. So there's a really excellent shift there of people who've been very disabled over to those who have an excellent recovery in MRS 0 to 2. The criteria for thrombectomy at the time of these trials, back in the sort of mid-2010s, so 2015 odd, were that the clot needed to be removed at 6 hours. So that was one of the definitions of the trials. So realistically, you needed to be on the table of the interventional radiologist at about 5 hours, because it takes time to get the patient anaesthetized and get the equipment in and actually remove the clot. Before thrombectomy is considered, a CT angiogram is required, and that's to assess for whether there's actually something there to be removed, because clearly if there isn't a clot proximally in one of those big arteries, a thrombectomy wouldn't be appropriate. So clots that are in more distal arteries are unable to be reached by thrombectomy. So CTA is required. It does take a little bit of time, but actually, CTA can be done at the same time as a CT brain is done if the person who's requesting it is mindful that it might need to be done. It does require contrast, again, for the benefits that are conferred by possible thrombectomy. It's something which is worthwhile doing. The trials did specify that patients shouldn't have a very poor functional state before thrombectomy. So the MRS pre-stroke would have to be 0 to 2. And the NIHSS, which is the National Institute of Health Stroke Score, it's essentially a severity score of how bad a stroke is. It does have to be more than 6. So it has to be a stroke which is going to significantly impact on function. Similarly, the initial CT has to show that there isn't already extensive infarct, because as we've already said, if there's hypodensity on the CT, that is unsalvageable brain. So going in and doing this procedure isn't going to help if you've already wiped out the whole of your MCA territory. So initial CT needed to make sure that that there is brain tissue that's available to be saved. I just want to talk briefly about my sort of passion, and Adam will smile when he hears me talking about this. This is a CT scan, a plain CT scan of somebody's posterior fossa. And what I'm really showing this to demonstrate is that this is the basilar artery. We haven't really talked about the basilar artery. We've been talking about anterior strokes. And if you look at the sequence of images, we're sort of cutting further up towards the vertex of the head. The left side image shows a normal looking basilar artery, which is not hyperdense. The middle one similarly showing a basilar artery at the front there, just in front of the pons, which is not hyperdense. Whereas the right-hand side image is showing a basilar artery there, which is hyperdense. So hyperdensity in a basilar artery indicates thrombosis or basilar artery occlusion. Why do I mention this? I mention this because basilar artery occlusion usually results in brainstem death. Infarction of the brainstem, which either leads to death fairly rapidly, or things like locked-in syndrome, which are horrendous. So prognosis from basilar artery occlusion is horrendous. Basilar artery occlusion can be quite difficult to recognise because it can cause quite fluctuating symptoms. So the brainstem can be quite forgiving sometimes for a short period of time when it's ischemic. So people can sometimes get very symptomatic with dizziness, vertigo, vomiting, drowsiness, which can then improve and then get worse again, and often will then progress to coma. So it can cause fluctuating symptoms, and sometimes we don't think about stroke when people come in with reduced GCS. And my mantra, and really one of the key messages again that I want you to take away today, is that any patient who comes in with unexplained low GCS or coma is basilar artery occlusion unless proven otherwise and warrants a CTA. So if you don't have an explanation why someone has been found unconscious that's viable, you should be thinking about getting an urgent CTA to rule this out. Particularly if the plain CT shows that there's hyperdensity in the artery, although that isn't very sensitive. So if you suspect it, you should do a CT angiogram to rule it out. With basilar artery occlusions, because they're so horrendous in terms of their prognosis, we do thrombolyze and do clot retrievals later, and there's evidence that even up to 48 hours, patients can get benefit from this. And again, that's likely because the brainstem is slightly more forgiving and has a slightly different collateral supply to anterior. So even if you're 12 hours down the line with someone that you suddenly think they may have a basilar artery occlusion, get a CTA. It may be that you can still help the patient. That sort of leads us nicely into timing, really, because we've talked a lot about time windows in the trials that we've talked about. So with the thrombolysis recommendations at the moment, the time window is 4.5 hours. We wouldn't thrombolyze people after 4.5 hours based on the evidence that we've talked about. And similar for thrombectomy, we've talked about the 6-hour time window. It's sometimes very difficult to know when a patient's had their stroke. So 25% of strokes are in patients who wake up with their symptoms. And in those patients, we've always taken the time of their stroke to be when they were last seen well. So if they go to bed at 11 o'clock, and they wake up at 5 o'clock, and no one's seen them during the night, and they haven't said that they've gone to the loo or something like that normally, then actually you have to presume that their time of onset was 11 o'clock, and that's 6 hours ago, and you've kind of missed your time window for that. Similarly, there's people that we catch really early. So there's people who we catch whose symptom onset was an hour and a half ago. They've come to a thrombectomy centre. They've had a perfect thrombectomy, and actually they don't recover, despite having a beautifully looking angiography post-thrombectomy. And that's really annoying because actually the trials say that shouldn't happen. And again, that really comes down to what's actually happening physiologically in these patients. So brought up this graphic again because I think it's really helpful. Normal circulation on the left, as we talked about earlier on. So with normal flow going through a number of arteries and anastomosis giving a good collateral supply. Some patients will have a really poor collateral supply, and particularly people who've got atherosclerosis, or often in the elderly because of atherosclerosis. Their collaterals will be poor, and actually when a clot forms, they will infarct very, very quickly a lot of brain tissue because there just isn't that collateral to try and keep alive a penumbra. And that probably accounts for why some people we intervene early and we get a really poor outcome. It's probably because actually their collaterals are poor, and even though we've caught them within the 4.5 hour or 6 hour window, we've already lost brain and there's nothing there to salvage. What's really important to us and really exciting is that we do see people who've got really excellent collaterals, and even 6 hours, 12 hours down the line, there's still salvageable brain tissue there. And they're really a really interesting and really exciting cohort of people, often because they're young. So young people often have good collateral flow, and because it's changing really the parameters of how we think about intervening in stroke. So whereas before we would think very much about a time window, what we're starting to think now more about it is something which can be termed as sort of a tissue window. So actually the tissue that this patient has that's individualized to them, what is it doing, and how long have we got to intervene to save it? So that's really exciting. And it's something which there's a lot of research going on at the moment to look into to see, are we using the correct time windows or should we be using more tissue windows? One of the things that we've noticed is that MRI can be quite helpful for this. So MRI, there's lots of different sequences that can be done, but as stroke physicians, really, the ones that we love are the FLAIR image, which is fluid attenuated inversion recovery images. And this essentially shows us the content of water of the brain. So when the brain starts to develop edema, it will show up as a hyperintensity on the FLAIR image. DWI is diffusion weighted imaging, and that shows or detects the movement of water. So not so much the water content, but how freely water is moving across tissue. And that can show very early whether brain is ischemic, even if it hasn't developed edema yet. There was a nice study in 2011 that looked at patients who'd had strokes and who'd had MRI scans that looked at whether we could predict the time window that a stroke happened based on the differences between FLAIR imaging and DWI. And actually what that showed was that when the FLAIR image is normal, i.e. when edema hasn't developed, but when the diffusion weighted imaging is abnormal, i.e. water is being restricted and there is ischemia there, that's got a pretty good correlation with the symptoms starting within 4.5 hours. So actually, rather than having a time window there, you've got a sort of an imaging window which can detect how recent a clot has got lodged in the circulation and has caused a stroke. So that had a pretty good positive predictive value. So 83% were detected with what's called a DWI FLAIR mismatch. So findings on the DWI, but not on the FLAIR. Negative predictive value, not quite so great. So there were patients who had changes on both, where their stroke was still within 4.5 hours. And again, that undoubtedly comes back to this concept of collateral supply. So actually, if you've got really poor collateral supply, even if your stroke is within 4.5 hours, you're probably going to have infarcted and developed some more edema than you would have done had you not had such a poor collateral supply. The other sort of very exciting progression is with something called CT perfusion imaging. So CT perfusion imaging sounds very complicated, and the image I've shown you probably looks very complicated, but actually doing it is not so complicated. So a CT perfusion requires that obviously the patient has a CT scan. They also have an injection of contrast, and the CT scanner then takes images at varying times, I think up to about a minute afterwards, and then through some very, very complex tech and computer generation, produces an image. And the image that you see in front of you is one that is generated by an app, which excitingly we're about to start using in University Hospitals Dorset. This is called Rapid AI. And the app essentially takes the imaging information from the CT scanner, and then by artificial intelligence and some very complex computing, develops a map, which you can see here, which shows you on the left, infarct volume. So this is the tissue which is dead and which we can't salvage. And that's shown in pink over on that left-hand side. What it also tells us is areas of the brain that are ischemic, but are not infarcted, i.e. penumbra. So this is salvageable tissue, where there's collateral supply that's keeping it alive, but this will infarct if we don't do something about it soon. So collateral supply is good up to a point, but then often fails to produce further infarct. This app is really good. It tells you what the mismatch is, so how much brain volume you have to save. So in this patient, as an example, it would be 63 mils. And it even tells you whether thrombectomy may be indicated. So it's kind of doing my job for me in a lot of ways. But you know, for a stroke physician who's on call for thrombolysis, who's at home, having this sort of information on an app to advise whoever's seeing the patient is brilliant, and I think is going to really revolutionise, you know, what we can do so long as we can get this imaging done. There are other techs available. This is Rapid AI is the one that we're about to start using, but there are other AI companies that are rolling this out. And hopefully this will start to be much more available from a cost point of view and availability point of view. I know that in our region, availability of Rapid AI has been developed as a sort of strategic regional level. So this has been done in conjunction with Southampton, which is our thrombectomy centre. And certainly, you know, the district generals and the HAZUs that don't do thrombectomy are benefiting from the links that we're having with those centres. So a really good case for sort of working as a region and as a team. So these imaging modalities are really helpful for us to see actually, you know, which patients should we be selecting to do our interventions on, and that's really exciting because individualizing patient care based on this means that we won't be doing procedures on people who won't benefit, and therefore we won't be putting them at risk. It also means that people who previously we wouldn't have been able to do these procedures on may get some benefit. So patient selection is really crucial. There's been a recent trial in 2018 called the Dawn trial, which basically looked at patients who woke up with stroke, or their symptoms were between 6 and 24 hours since they were last seen well. And it looked at, with those patients, if we did the MRI mismatching studies and found that there was indeed a mismatch, i.e. that although they were last seen well a long time ago, their stroke was likely to be within the last 4.5 hours, whether they benefited from thrombectomy. And essentially, looking at the infographic again, it works. So patients who we demonstrate is there's a penumbra, who we can get to thrombectomy, even if they're more than 6 hours after their onset of symptoms or when they were last seen well, there's a benefit. So they move MRS groups. So again, the bottom is the placebo there, and you can see that there's a movement of people from the lower MRS groups of sort of 5 and 6, which are the darker colours, into the lighter colours when they have thrombectomy. So patients do well if they're selected correctly and they go for thrombectomy. That was 6 to 12 hours. As I said, they did look at patients 6 to 24 hours, and even at 24 hours, there is still a benefit. So not quite as many people making it into the sort of MRS of 0, but still a significant shift of people who were going to do very, very badly, who maybe won't do as badly and may not need as much care. So a shift up that MRS scale. So really exciting and kind of petrifying in the same sentence, and I'll explain why I think that is later on. So similar to the Dawn trial, another wake-up stroke trial was the wake-up trial. And this looked similarly at people who were past the 4.5 hours thrombolysis window, who had this MRI mismatch. So people who had missed the traditional thrombolysis time window, but actually seemed to be in a tissue window where there was still salvageable tissue. And again, the results did show that there was an improvement in the modified Rankin scale. So putting these people through thrombolysis, if they had salvageable tissue, was beneficial on people's functional outcomes. Again, perhaps unsurprisingly, with thrombolysis, there was an increased number of people who had intracerebral hemorrhages, and again, that's played out through all the thrombolysis trials. That was a significant increase in symptomatic ICH, and it was also accompanied by a numerical increase in deaths. That wasn't significant; it didn't reach significance, but you can see the numbers are quite small there. And one wouldn't be surprised if people were put at increased risk of death due to ICH as a result of this. But clearly, there is also a benefit there. These results have been taken by the AHA, the American Heart Association, in their recent guidelines. And they have recommended that people who have a stroke, who are past the traditional 4.5-hour thrombolysis window, who have this MRI perfusion mismatch, can be considered for thrombolysis. So although it's still off-label, it is something that I think, in the next few years we'll be looking at to see actually whether it becomes common practice. So briefly now, just touching on what I think the challenges are and what the future holds for us, really. Clearly, the challenges that we're going to face are, all these things are great, and that it's brilliant that these trials have had, MRI perfusion imaging early and CT perfusion imaging early. But actually, on the shop floor in a busy DGH, we just don't have MRI scans, for any patient who comes in, and particularly if we're talking about, all patients within 24 hours of a stroke, it would cripple the service to do MRIs on everybody. So the availability of urgent imaging just isn't there at the moment, and I think that services would be put under severe pressure if we started to roll this out. If all strokes within 24 hours needed to have a thrombolysis call, that would make my job extremely busy and unfeasible. We'd need to really bulk out our front door teams, so our outreach teams. And in the current climate where there are unfilled stroke consultant posts, unfortunately, that's going to be an issue. So clearly, training up stroke consultants and increasing the number of people in post is really important. Similarly, there aren't the interventional radiologists out there to provide the volume of thrombectomy that this will generate. And there's a big recruitment drive for people to become interventional radiologists, interventional neuroradiologists. But clearly, training an interventional neuroradiologist takes a lot of time. And despite the fact that, programs are becoming available, it's going to be many years before we actually see people coming out the other side there. So although this is all really exciting stuff, there are pretty significant challenges there that are to be met. How I see the future, or what I would like the future to look like, is that a patient has a stroke. If they're close to a centralized HAZU, then they get there and they're met by a specialized stroke team 24/7 if possible, if not at least 7 days a week. There's an outreach team to meet them at the door, and imaging is done pretty much straight away. So again, in our current HAZU, they're met at the CT scanner, so imaging is really key and is important to be done urgently. They'll get a CT scan, a plain CT, which will look for whether they bled, and obviously if they bled, they'll go down the hemorrhage pathway. If they haven't bled, they'll have a CTA, so a CT angiogram that will look at whether they've got a large vessel occlusion, which might be a target for thrombectomy. They'll be thrombolized, probably in the scanner if able, while everything else is being done. And if there is a large vessel occlusion there, then they'll have a CT perfusion or MRI if it's available, looking at what brain tissue is viable and what benefit they might get from thrombectomy. And I would hope that will be regardless of timing, just given those trials that we've looked at. And I think that with that, they'll then go on to have their thrombectomy. It would be brilliant if every centre had a thrombectomy service, which clearly is going to be a massive challenge. And I think, will be difficult because of the numbers coming through. So I think there will always be a tendency to have thrombectomy specialised and concentrated in one place. But there'll be easy access to thrombectomy, and the sort of streamlining of the services to get people into thrombectomy will be excellent. And then hopefully we'll get people, thrombectomized and thrombolized as soon as possible, and really continue to increase our stroke mortality. So I'm going to round off there and just say that really my key points, I think, are that stroke care continues to evolve and really has come on, masses really in the last decade or 20 years. It's really exciting, and I think that for us as doctors it's exciting, and I think that for patients and for the general public and us as a population it's exciting, because trying to reduce some of the morbidity from stroke and the mortality is going to be key. I think we're going to move much more towards a tissue window more than a time window. So I think that these 4.5 hours and 6 hours will definitely be more muddied. I think that there's going to be massive challenges in resourcing these changes, both radiology and staff. But I think that we need to work together to overcome those. And I'd really would like it if the one message that you came from this was please don't miss a basilar artery occlusion. So anyone who comes in with an unexplained low GCS, particularly if they've had posterior symptoms in the lead up, really needs a CT angiogram to rule out a basilar artery occlusion. And I think that is me done. So I'll take any questions from you via Adam.
Great, thanks very much, Nick. That was a fantastic overview. Thanks very much. We have got quite a few questions actually. We've had quite a few on the chat function. I've had a few emails coming in as well. So if I may, I'm going to start by answering the first of them, which is one of the delegates has asked, will your slides be available elsewhere to catch up with later? So there's obviously a lot of information there. And the answer is yes, they're available on Doctors.net, who will upload them so you can look in one of their e-learning modules. And also, if you go to UKGIM.com on YouTube, then the presentation will be available there for you to catch up on at a later date as well. It's also going to be on the website, UKGIM.com, just in the webinar section. So I'm going to go on to some of the questions now. One person has asked, what do you feel the role is for pre-hospital antiplatelets, so aspirin or clopidogrel, in someone as they come in to the hospital, if you're thinking about an acute stroke? Should we still be giving that?
So I think if it's an acute stroke, i.e. symptoms are still present, then no would be the answer. And the reason for that is that we haven't yet ruled out a bleed. So there's some trials going on or have been on where they've had a mobile CT scanner, which would be amazing. So getting the scan out in the community. But if someone's got persistent symptoms, you have to presume they've had a stroke. And until you've done a CT scan, you can't rule out a hemorrhage and therefore shouldn't be giving antiplatelets. Clearly, once hemorrhage has been ruled out by a CT scan in the hospital, getting antiplatelets in, if you're not doing the other interventions, would be a priority, but not pre-hospital and pre-CT scan.
Thank you. Somebody's asked, you mentioned that essentially brain is neurons, and actually the sooner we can thrombolyze, the better people do. How many TIAs do you have the feel that we actually thrombolyze? So people would have got better regardless of the treatment. Is there any sort of work around that?
I think it's really tricky to know that, because as some people that we see who come in with strokes do get better. And obviously we don't know that until 24 hours, so it's very difficult to wait that long. I don't really think there's a clear answer to that. I think that it would be unethical to do a trial looking at that now. We have to presume that some people, yes, would be a TIA. I think that the things that really would drive you against thinking that it would be a TIA is if you do a CTA and there's a clot sat there. So really, with the number of CTAs that we're now doing, we are seeing actually quite a few people who come in who've got fairly minor symptoms, so low stroke scale scores, who actually you do a CTA for and you actually find there's a clot sat there, and they're presumably the people who are going to go on and actually get worse rather than better. So I think it's really tricky, and we do see people who come in who evolve and get worse, and we do see people who come in who get better who turn out to be a TIA. I think CTAs are really helpful in gauging who's going to do what, because like I said, if you've got a clot there, it's likely that that's going to propagate or get worse, or it's not something that's just going to dissipate. But that's a fairly evidence-free reason. I think will remain so just because of the ethics of doing a trial.
That really brings me on quite nicely, actually, to the next question, which was, if a patient is admitted and thrombolyzed, and then they were to deteriorate from a stroke point of view, ischemic stroke, perhaps immediately or several days down the line, how quickly can you re-thrombolize somebody?
So I wouldn't re-thrombolize somebody within a week. So the reason for that, and perhaps just linking back into the TIA question, is that the more infarcts that you have, the more at risk you are of bleeding. So clearly when we're thrombolizing people early, we're doing that because hopefully there isn't a huge infarct volume there. And similarly, it's why we're very cautious with people who've got massive infarct volume. So people who've got the whole of the MCA and ACA that's already infarcted, we wouldn't thrombolize them because there's such a high risk of bleeding of that infarcted tissue. Clearly, if you've had a stroke with persistent symptoms after the 24 hours or with imaging that shows that you've had a stroke, that area will be very, very high risk to thrombolize, within the week. So within 3 months, I think is the exclusion criteria in certainly our local hospital protocol. Interestingly, when we were talking about thrombolizing TIAs, the other interesting thing to think about is that it computes that the risk of getting a bleed or something following a TIA may be smaller than if you're actually having a stroke, because actually the amount of infarcted tissue with a minor stroke or a TIA is presumably less than the bigger strokes. That's not to say that people don't have other risk factors for bleeding, so things like cerebral amyloid that can bleed. But I wouldn't not thrombolize someone on the basis that they may be a TIA.
Oh, yeah, yeah. Great. In terms of thinking about contraindications to thrombolysis, obviously there's the original list of things, and some of those things were being older than 80 years old, things which perhaps most of us would feel were probably not true contraindications anymore. One of the things which I know has come up relatively frequently is people that have had recent sorts of surgery or some sort of, a pacemaker insertion, something like that. What's your feeling around thrombolysis in someone that's had that sort of procedure in the last couple of weeks?
So I think the first thing to say is if you can thrombectomize them, do that instead, because actually the risk of bleeding from that is low. So if you're in hours and you're within time, thrombectomy would be the preferred option if there was a large vessel occlusion. I think you're right. In my mind, there are a few absolute contraindications. There's lots of relative contraindications to thrombolysis, but not a lot of absolute ones. And it all really is balanced on how severely the stroke is going to affect someone and how likely they are to bleed and how you might stop that bleeding. So, for example, we've had people who I've seen who've had a renal biopsy 7 days beforehand, who are having a major stroke, and we've called the renal physicians, and they've said, the urologist, and they've said, actually, crack on and thrombolyze them, because actually, if they bleed, we can do a nephrectomy, we can kind of tend to bleeding, whereas if they have a stroke, they've got a 1 in 4 chance of dying, within 6 months. So it's all really balanced on that. And I've had a patient who had a coronary artery bypass graft 10 days beforehand, when I was a thrombolysis consultant on call, and he was having a massive stroke. And again, in conversation with the cardiothoracics after we couldn't get a thrombectomy, it does end up being a sort of a do or die situation anyway, because these huge strokes have got such a terrible mortality that actually, you're sort of doing the patient a disservice if you don't discuss doing it anyway with the risk of bleeding. It does cause sleepless nights though.
Yes, yeah, absolutely. Okay, thank you. I'm going to move on a little bit. There's a few questions around hemorrhage. And somebody's asked, what's the role of things like tranexamic acid in people who have a hemorrhagic stroke but aren't on something like a DOAC? Is there any use for that?
There isn't, no. So there's been trials looking at that, and there's no benefit of using that. So we don't use tranexamic acid.
Thank you. And I guess there's probably some risks around thrombotic risk with PE and DVT.
Exactly, yeah, and the sort of side effects that stroke patients are at risk of, like you said, because of their immobility and things. Yeah.
Okay, thank you. And then in people who do have a hemorrhagic stroke, what sorts of patients should we be talking to the neurosurgeons about, and what sorts of things can they intervene with?
It's a tricky one. Clearly, people who are not going to be a candidate for neurosurgery, and under any circumstances, we probably don't need to talk to them about. That would be, a patient, say, who had a very poor MRS pre-stroke, so if they had an MRS of 5, say, or who had, a sort of a life-limiting condition that's going to, rule out surgery altogether. What essentially we're asking the neurosurgeons to do is to do a hemicraniectomy and evacuation of a clot, which is a huge operation. So again, people who are very frail are unlikely to tolerate that or to have a good benefit from it. The other sort of bleeds which are difficult for the neurosurgeons to intervene in are deep bleeds, so things like basal ganglia bleeds, where actually to get to the clot they have to dig through, good brain, which often leads to quite a lot of deficit. It's really difficult. I think that different neurosurgeons would say different things. Some would say refer all or discuss all. Some would say, be a bit more pragmatic. And as a geriatrician, I think I lead a bit more to being pragmatic and saying, actually, if the family said that this patient would not want neurosurgery, then we wouldn't do it. The other thing to keep in mind is that sometimes, they can do things like extraventricular drains to relieve hydrocephalus. So there is a role, particularly if there's compressive symptoms. But, if you've got someone who's had a massive, volleyball-sized hemorrhage, they're not going to evacuate that because that the patient is going to die from that hemorrhage. So I think it's a call that you have to make based on the frailty, whether they're going to survive the operation, and whether they're going to have an MRS of 5 should they survive, which the family wouldn't want particularly, or gauging what the family would want. But to be honest, I don't think there's a hard and fast answer, because there's people that I've spoken to neurosurgeons about that I thought we definitely shouldn't discuss, and they said we should have discussed it. We won't do anything anyway, but we should have discussed it. So it depends on how brave you're feeling, I guess.
Yeah, and I guess if there's any doubt, it's always worth just taking advice, isn't it? Absolutely.
Yeah, and I think just knowing what you're asking is the important thing. So
yeah, thank you. As you know, there's antidotes for things like dabigatran, and that sometimes affects the choice of DOAC, if perhaps people are fallers and that sort of thing. I understand that there's soon to be available other reversal agents, things like rivaroxaban and apixaban. Mm-hmm. Are you aware of them coming into sort of common use for hemorrhagic transformation and treatment of that?
So the antidote you're talking about is adanexet, which has got a much more complicated MAB name. So that's been coming through for a few years now, and I think in America it's now been licensed by the FDA. I'm not aware that it's been licensed here yet, and certainly I'm not aware that it's available widely. I think the hope is that it will be. So watch this space, I think.
Absolutely, thank you.
I think again, it's important to remember that these antidotes stop hematoma expansion, but actually there's already hematoma there. So actually getting people to come to hospital early is a key thing. So trying to get the message out to the public that actually if you have a stroke, don't wait on it, actually come in, because by the time that people often get here, the hematoma has already expanded and done its damage. So the quicker that people can get into us, the quicker that we can try and reverse things and stop that.
Great, thank you. Well, thanks very much, Nick. Thanks very much, Nick. In the interest of time, I'm going to say that was the last question. I'm afraid there's still many more, but thanks ever so much, Nick, for joining us this evening. That was an absolutely superb presentation, a really good overview of stroke. It's such a rapidly changing field at the moment, and actually to know what's on the horizon, what we can do at the moment, and what we will be able to do soon is really, really helpful. Obviously going to be a great challenge, isn't it, with the training of the people you need to do the work and having the resource to be able to do it. So I guess it is a case to watch this space, and I guess services are likely to be centralized over the next few years and that sort of thing, aren't they?
Yes.
But thanks very much. That was absolutely outstanding overview. So thanks, Nick. I'd also like to thank the audience. Thank you very much for joining us this evening. I'm afraid this is going to be the last of the UKGIM webinars for 2020. We're going to have a break over the Christmas period, but I hope you can join us in the new year. I'm hoping we all have a slightly better new year than 2020's been. As you know, we started these webinars in response to the COVID-19 pandemic, and we all hope that this vaccine does what we want it to, and that we can start living slightly more normal lives. But I wish you all the very best for Christmas and the new year, and thanks again for joining us, and I hope you all have a very pleasant evening. So good night.